Today talking about, should I start again? Hi, everybody. My name's Sarah Rosenberger. I'm here with Gabrielle Grayson and Heather Lawson. We're going to be talking today about aortic disease management and CT imaging for diagnosis and surveillance, and some pearls and understanding what we're looking at. So I'm going to get this going. We do have a chat feature, so feel free to enter things into the chat. We'll have sort of a little bit of a structured talk to begin with, and then hopefully, foster some good conversation. All right, as I mentioned, my name's Sarah Rosenberger. I am the aortic program manager at University of Maryland Medical Center in Baltimore, Maryland. And the content that I'm going to share with you is my own opinions. SVN, I am a member of SVN, and I am co-chair of our education committee. But what I'm presenting does not necessarily reflect official opinions of the Society for Vascular Nursing. All of the patients whose images that I'm using today consented to have the use of their images shared for this webinar. And obviously it's been de-identified, and I have no financial conflicts of interest. So as I had mentioned kind of briefly, just to kind of give us an agenda for our time together, we're going to talk about the planes and phases of computerized topography, also known as CT angiography or a CTA. So you know when you are ordering it or your patient goes down for this, what images you're getting and how each of those pieces can be used. We're going to talk a little bit about endograft treatment for aortic aneurysm and how that relates to the need for surveillance follow-up. And then we're going to use some clinical examples, some of my own patients, to talk about or look at examples of native aortic disease, endografts that were successful, and endografts with the dreaded endo leak and different types of endo leaks, and how worried we need to be about those. Okay, so we'll start by talking of the planes of a CT scan. So this is just sort of general terminology that you should know, and when you're navigating a CT scan, you want to be familiar with the fact that you can view this image in 3D in multiple different ways, right? So the way you get a 3D picture of the patient's body is by being able to look across these different planes. The axial plane is the horizontal plane, and how we describe this to our patients as they're going through the CT scanner is that this is like you've laid your body out like you're laying in bed, and they've sliced you like a loaf of bread. So this is how the pictures are taken. This will be the thinnest cuts. So, usually somewhere between 2 and 6 millimeters in between each picture that goes through the whole body. And that is the actual photos that are taken as they go through the CT scanner. The coronal plane is sort of a frontal view, as if I was looking at the patient, but I can see 3D into their body. And the sagittal plane is sort of a profile view of their body. And those are reconstructions that the computer is able to do with the axial images. So the other thing to know, and I'm going to try and to make sure I protected patients' de-identified information, I have this as sort of videos, but I'm going to try and start and stop it as we go. So if you're looking at your images in an electronic medical record, your CTA will have multiple series of pictures. These series are the different cuts and different phases of the CAT scan. You may not know when you order or when your patient goes down for a CTA angiography, you are ordering 3 phases, 3 runs through the CAT scanner. The first is a dry scan with no contrast. The second is contrast dye that's timed with a heartbeat, so we can see how the blood is flowing through the arteries. And then the third time is a delay phase. So they wait about 3 to 5 minutes, and then there's saturation of the contrast dye in all the arteries and veins, and you can get sort of a delayed picture of where blood flow is getting maybe at a slower pace. So you can know which image is which by looking at these small little numbers on each series. So if there's only 2 images in this series, that's the scout image. That's the image that the technologist took to make sure the patient was centered and they had good penetration of the body. Then these other images will tell you and these names, which are sometimes not always named consistently, will give you an idea of which series you're looking at. Typically, the arterial axial images will have the most pictures in the series because, like I said, that's the thinnest cuts and that's the actual imaging, as opposed to the reconstructions, which are thicker cuts. So yeah, this mouse is just sort of orienting us to what I just said. Apologize, that's not super clean. And as I scroll through here, we see these delays and then these reconstructions. Okay, so let's start by running through a CT scan. This is a chest, abdomen, pelvis of a patient with aortic aneurysm. Whenever I'm getting a CT and I have the luxury of having a chest, abdomen, pelvis, where I usually orient myself is at the aortic arch. So here where the aorta looks like a tic-tac, this is where I know exactly where I am in the body. So for those of you who don't look at CAT scans all the time, and I preset this to the CTA window, so you can have different amounts of exposure or penetration, kind of thinking about like if you were a photographer and you put different exposures on, you know, you put it in the dark room for different exposures, you could get different penetration of the pictures. So this is specifically designed to be able to tell the difference between the hardest, densest material, which is bone or atherosclerotic calcium, and the density, the increased density of the blood flow because you've added that ionized contrast. So the ionized contrast is denser than regular blood, and so this will light up more than regular blood. Not as much as this atherosclerotic or calcified plaque, not as much as this vertebrae or these ribs here. And the least dense material, the lungs or the air within the lungs, is black. You can see subcutaneous tissue is less vascularized, it's less dense than, for example, muscle, which lies underneath it. So you can see sort of these different shades of gray. The skin is denser than the subcutaneous tissue, so you can start to see the different tissue types. But again, this penetration, this exposure that we have it set to is ideally designed to be able to help us distinguish between firm plaque, where arterial blood flow is going, and where there might be mural thrombus or other issues. So as the CT scan runs, you're going to follow. Here is the aorta. I'm going to pause right here to say, we all know the magic number of 5.5, a fusiform aneurysm. That's 5.5 is going to be kind of that hard criteria for surgical intervention. But the definition of aneurysm that I think sometimes gets lost with that one number is an aorta is aneurysmal if it's 1.5 times the normal size. And not everybody's normal size aorta is exactly the same size. Just like we are different heights, we have different size feet, people have different size aortas. A 6'6" male is likely to have a larger normal aorta than a petite 5-foot female. And so a good rule of thumb that I like to use is the vertebrae should be about the same size or bigger than your aorta. So even with a cursory glance, as I watch the spine compared to the aorta, I can tell whether or not it's about the right size or not about the right size by comparing it to the spine. And we know the normal course of the aorta is that it runs to the left-hand side of the spine through the thoracic cavity, because the heart is anterior and you've got the, pulmonary artery in the lungs in this middle section. And so it's displaced a little bit to the left. And as we get to the diaphragm and into the abdomen, you'll see that it naturally rotates anteriorly and through the abdomen sits directly in front of the spine. Now here you can see this is starting to get a bit larger. You can see that the aortic wall is actually way out here, but you have calcium and blood flow through here. There's mural layering thrombus because it's not laminar flow, because the blood flow wants to take the shortest path, but this is still under pressure. So let's continue to follow this down. Now you can see this has gotten much larger. And another kind of interesting thing about aneurysms is they grow not only in diameter, but also in length. So a patient with an aortic aneurysm not only has a large diameter, but it'll take sort of a twisty, turvy course through the body, because if anything, our spine's getting shorter as we age with degenerative disc disease, but the aorta is getting longer as it becomes aneurysmal. So you can definitely see that in this patient. All right, so that's the run through of this patient's aorta. You can see a lot of calcified plaque. When I look at this patient, this is probably where, this is a still shot from that video. This is probably where the aorta looked the biggest. And I want to talk here about how we measure the aorta and some pitfalls in measurement. So here is the anterior posterior diameter wall to wall. As you can see, there's ionized contrast in here, so this is denser, but there's a lot of layering mural thrombus, and that's because the blood is sort of swirling or forming eddies, and then it sort of layers in sort of this soft clot. But the blood pressure that's coming through this section of the aorta is putting pressure on this thinning wall. This measurement, this lateral measurement, is a falsely elevated. And you'll understand why when I show you the coronal pictures, but this is often reported by radiology or other non-experts. They go very concretely by an anterior, posterior, and a lateral dimension. Fusiform aneurysms tend to be symmetrical. Let's see if I can get this to play. Oh, this is playing awfully fast. All right, so you can see here the aorta, it takes sort of like an S turn as it comes through the body. And so the anterior, posterior, or completely horizontal measurements are not really a true reflection of that pipe's diameter, because the pipe is sort of tilted. You get the next picture, which I think can show you here. So, the anterior posterior dimension on the previous image was 5.9. And here you can see that the lateral measurement of this aneurysm is also 5.9. The true horizontal axial plane maximum measurement is catching the aneurysm at an angle. So imagine if you had a cucumber and you slice it on an oblique angle. You can make your cucumber slices oval, but that doesn't mean you have an oval-shaped cucumber. The cucumber is actually still round. There are other aneurysms that can be asymmetrical, but that's a whole nother topic for a whole nother day. Most aneurysms are going to be fusiform aneurysms. That's the fancy name for round and degenerative. So if you have a really egg-shaped or oval-shaped aneurysm on your axial planes, or the measurements that you're getting from radiology are pretty asymmetrical, you should sort of question that in your head and say, are they actually getting a true measure? Now, in this patient's case, whether her aneurysm was 6 centimeters or 7 centimeters, she needs to have a repair. But this can become clinically significant. We get a lot of patients referred to us with a 5.6 centimeter aneurysm, and it's actually really 5.1, and it's just sort of lopsided. So, certainly those patients should be connected to a vascular surgeon, and they should be followed. But they don't necessarily need surgery as emergently as sometimes the lay person or the radiologist or the PCP thinks. The second pitfall, which I didn't even mark on here, that radiologists love to do is give you the length of the aneurysm. The length of the aneurysm is important if the surgeon is planning a surgery and sizing a stent, but it has no relation to whether or not the aneurysm is going to rupture. And so they will give you, this measurement would probably be something like 11 centimeters long. And all the patient reads is, I have 11 centimeter aneurysm. And so the risk of rupture for an 11 centimeter aneurysm is a heck of a lot higher than a 6 centimeter aneurysm. And it creates a sense of panic or urgency, not only for the patient, but for non-experts. So the length measurement is really unhelpful. And if you have uneven measurements, you should really take advantage of those reconstructions in the coronal or sagittal planes to get more accurate measurements. And I think just to round this picture out, here's a sagittal view of the same patient. don't know why I paused there. And you can see the tortuous, you don't see a connected aorta because these slices are profile slices, and as it's coursing back and forth through the body, you don't have a single shot that can catch it all. However, this AP measurement that was on the axial plane is not terribly different from the true diameter of the aneurysm, despite the fact that it's tilting a little bit forward. So the amount in which that's going to matter or make a difference is really dependent on the way the aneurysm is sitting inside the patient. So before we go on, I want to talk a little bit about endografts. This is probably an audience that knows a lot about endografts, but I'll explain it again to reinforce and also to give you maybe some terminology you can use when you're talking to your patients. I think most of our patients are very confused when they find out that we didn't remove their aneurysm, right? So the purpose of endograft is prevent rupture. And rupture occurs because the sac is pressurized and this weakened wall cannot withstand the pressure. So the endograft uses radial force. It's pushing up from the inside against the wall of the aorta, directing blood flow through this stent graft, thereby depressurizing the aortic sac. So eliminating the risk that the sac would rupture because it does not have an increased pressure that's pushing outward force. I'm going to pause my share for a moment because I brought home with me a couple of, let me see, I have my background blurred, a couple of EVARs. And there's different brands and they have different strengths and weaknesses. But I think an important thing to know is that these can be made of a couple of different materials. They're relatively large. They sometimes have struts that extend beyond the fabric. They sometimes don't. And as you can see, just like we said, patients have different size shoes. They can have very different size aortas. These are both intended to go in the infrarenal aorta, so you can see quite a variability in size. And I think this is helpful in viewing one long leg and the second leg, so I can go back to sharing my screen. And you can see that there's always at least one seam, for lack of a better word, or component fitting where pieces of aneurysms need to fit. Dr. Parodi's original EVAR back, in the late 1990s was literally just a straight segment that ended here. But now we have at least branches into the iliacs. And for those of you who work in bigger aortic centers, you might have branches going into the kidneys or other vessels and up through the chest. So the goal is blood is flowing inside the stent graft. And because of that fabric, the blood cannot get into the sac, therefore the pressure cannot get into the sac. So here's an example patient. Again, we're looking at axial images. This is set for contrast to enhance blood flow through the aorta. And we'll run through this. This is just an abdomen pelvis, so we don't have that tic-tac to orient us, but we can see where the aorta is moving in front of the spine, and we have our aortic sac there. So I like to pause here to say, here you can see where the contrast and the iodine is in perfusion, and so the blood that is in circulation is lit up. But here where the aortic sac remains and is depressurized, the blood that was in that sac at the time when the stent was deployed got trapped in there. And just like Jello, it's solidifying and congealing and essentially forming a non-dangerous blood clot that is, hardening around the aorta. As that blood sits and coagulates, the body will reabsorb a lot of the moisture out of it, and that's why you can see some sac shrinkage. But you don't necessarily expect to see the wall of the aorta completely adherent in the body of the aneurysm. So you can see this playing out all the way down. This patient does have a small internal iliac artery that we're watching. Maybe one day we'll get an extension. And then as we talked about, the patient gets that first run through that's dry, that second run through that's timed with arterial perfusion, then you wait about 3 minutes and run the patient through the scanner. So this is the same patient, and it's a run through the delay phase. So what you see is there's no difference between the arterial and the venous blood in the heart. It's a lot less crisp and clear, the blood in the aorta. As we come down, you can see, oops, I pressed the wrong button. Oh, okay, well, I messed that up, but here are still shots from that. So here's our venous phase, here's our arterial phase. You'll see the arterial phase is much more contrast. Here's the artery, here's your vena cava. In the delay image, your aorta inside the stent and the vena cava should be about the same color. You'll also see, mesenteric artery and vein. These light up the same. So some of these images will look different. What you're looking for when you're looking in the sac is to see that there's no contrast dye inside the sac, whether it's arterial or venous phase. So now let's talk about endoleaks. Endoleaks are the Achilles heel of endovascular treatment. And I think, again, this is probably stuff you already know, but really good to reinforce and remind your patient that an endoleak is not necessarily failure of treatment. The goal of treatment is prevent aortic rupture. And so if we have an endoleak, we might need to intervene upon it, we might not, and it doesn't mean that our entire surgery necessarily failed. The second thing the patients will say is, you didn't do the surgery right 10 years ago when you did my EVAR because now I have an endoleak. We didn't actually fix the biological problem that is aortic aneurysm. What we did was we took the pressure off the area of disease to prevent rupture. And if we fast forward in life 5-10 years, this part or this part can similarly become diseased. So the area that we were reliant on the stent graft pushing up against the aortic wall, if that aortic wall becomes weaker over time or aneurysmal, then this is sort of just floating into space. And I should be doing this here because that becomes a type 1 leak. A type 1A is when the top of the graft is floating in space. A type 1B is when the bottom of the graft is floating in space. Because, for example, that patient whose aorta I just showed you, he has an internal iliac aneurysm that eventually could cause his endograft to fail. And so often that, can result in extending the endograft to treat the area that has now become involved in the disease. And then a type 2 endoleak, which is not even well imaged here, but I think the patients often really don't think about, is that this aortic trunk not only has these main vessels going to the kidney and these main vessels going to the legs, but it also has small vessels coming off all along the course of the aorta. Namely, we have the small intercostal blood vessels that perfuse the intercostal muscles and the anterior spine in the chest, and those same blood vessels that are called the lumbar arteries that are perfusing, the musculature of our back as well as our spinal perfusion through there. And if the blood can come through its normal channel and then through collateral flow or arterioles or, retrograde circulation, it can find its way in a negative pressure stream because this is now depressurized. So if it can find its way through and the pressure is still lower in this sac than it is in the side branch blood vessels, blood can continue to flow into this sac. Eventually, as the blood that's sedentary and sitting in this sac hardens and it exceeds the pressure of the arterioles, this should naturally thrombose off to the next branch point. Think of it like if a road is closed, let's say the highway, there's a full multi-car accident on the highway, they close the whole highway. There's a stretch of highway that has nothing on it until the next on-ramp, right? So it'll thrombose until essentially the next on-ramp or wherever else it's going to take blood flow if it is a road to nowhere. All right, so we're going to talk first about our most dangerous type of endoleak, which is our type 1 endoleak. So again, just to orient, here's the heart. You can see we're in the arterial phase because the left ventricle is awfully bright compared to the right side of the heart. Here is the vertebrae. We're in the lungs, so we're in the chest cavity. Obviously, the heart's there. And then here's the aorta. And here you can see, maybe I let it run a second more. Here you can see our stent graft that was placed, and the aortic wall comes all the way out to here. So you have just as much high pressure flow going through the aortic graft stent as going into the aneurysm sac. This aneurysm sac is under the weight of the full arterial pressure. So this risk of rupture is based on full size, and having the endograft there provides you no protection. Okay, and then here is the sagittal view of the same. So again, you see here's the mesenteric blood vessels just to orient you, and we'll jump to this where I have it still. So here's our axial plane, it's coming on both sides, and here in the sagittal view, you see the end of the stent graft. The aneurysm is coming around through here, and plenty of blood is pressurized, flowing on the outside of the stent. So again, orienting, that's a type 1A endoleak. So the treatment for that is going to be to extend up to an area where the aorta is normal and we can rely on that radial force. I don't have a picture just for the sake of time of a type 3 endoleak, but that is a similarly pressurized sac that you see on the arterial phase that comes out of one of these components. And it happens when the stent folds on itself, or if the aneurysm, as I mentioned, they get longer, pulls the aortic components apart, because you can imagine this part is adherent to the iliac artery, and this part is adherent to the aorta. So if this segment gets longer, those two pieces can be pulled apart. And so a type 1A or a type 1 or a type 3 endoleak always requires intervention, because that sac is pressurized and you no longer have protection against rupture. The type 2 endoleak, like we talked about with the backwards flow, the arterioles and the smaller blood vessels through which this blood snakes until it eventually finds its way down into the depressurized sac, the blood pressure has lost a lot of pressure. And so it's very and it can cause the sac to enlarge enough that you lose radial force at the top or the bottom and cause a type 1 endoleak. So if the sac is not enlarging,
Sarah, I think we're losing your audio a little bit. Your connection, I think, is a little unstable, it seems.
is it better? Okay. Sorry
Yep,
about
you're back.
that. I'm back. I don't know if that was device malfunction or bad weather coming through, but this is a patient who has a type 2 endoleak. So we'll run through this. Again, I think I was pausing there because I orient myself at the aortic arch. This patient, we were lucky enough to have a chest abdomen pelvis. All right, so here in the arterial phase, we see the vena cava is not lit up. This sac should not be lit up. It should be about the same color as that. But we see this flash of brighter contrast there. And so I'm suspicious, why is there contrast in the excluded aneurysm sac? Now this is the delay phase. Again, pausing at the arch. That's how I orient myself to things. This is not as well timed because the blood hasn't made it all the way into the cava, but you can see that this, in the delay phase, we have more and different placement of the contrast in the aneurysm sac. So for comparison, here's the arterial phase and here's the venous phase. The arterial phase had this little wisp over here, and here at the same level in the venous phase, the blood has, the wisp of contrast has come all the way over here. This is much more subtle to see. And it's, like I mentioned when my screen was flipping out, it's a much more benign or less emergent finding because this wisp of blood flow into the sac is not the sac being under the full arterial pressure force. And so here is a sagittal view, again, taking advantage of all our views. Right here, you see the IMA is coming up. And that is what, if we follow this video, you can see this is what's feeding into that sac. You can see that contrast coming right in there, coming out of that IMA. So our surgeons would use this information to embolize this blood vessel so that this stopped feeding into this sac. Okay, so I have one more case study to share with you, and this is maybe hopefully going to get a little bit of audience participation. I want you guys to watch this CT scan and tell me what you think. What type of endoleak do we have? And here's the representative photo, so you can see you have your two limbs of your EVAR and contrast in the aneurysm sac. Okay, I'm going to play it one more time. Oh, go me, I did that when I was filming it. All right, and now this is the delay phase. This is the arterial phase again, sorry. This is our coronal view. All right, so I'm going to pause sharing right now. People can put in the chat who thinks that it is a type 2 endoleak. All right, Rebecca says type 1. Looks like Anthony says type 2. All right, let me go back to sharing so I can see. I close the chat. Alyssa says type 1. Bosa says type 1. All right, you guys are good. So I really wanted to include this one because
It's small.
it's small, exactly.
Mm.
Let me get back to sharing. Man. How many years can I do Zoom before I figure it out? Oh, I'm frustrating myself. Sorry. Can I make it pause? So those of you who saw this type 1 here, so here's the end of the stent, and here's contrast getting outside of it, type 1A endo leak. Now, those of you who thought it was a 2, you're not wrong, because there is definitely patent. Here is probably the IMA that's coming off the front here. And in the back, another branch vessel, if I can get it to stop in the right place, coming out back here. So as long as there's arterial pressure coming into the sac, it's looking for ways out, right? And so that might trick you into thinking it's a type 2, particularly if you don't notice the poor approximation at the top. I wanted to share this part here because you might, if you were looking at this, say, well, the struts of the stent are way up here and the contrast is right along there where it's a problem. But if you'll recall, I'm going to stop sharing now. Some of these EVAR stent grafts have fixation above the stent graft. So this part is meant to hook into and hold to the aorta, but then this part is the part that has to hold, that, you know, starts pushing up against the wall with radial force. All right, well, that concludes the didactic part of this roundtable. Thank you so much for your patience. I'm sorry I had some technical issues. Heather and Gabrielle, I'll turn it over to you first. Do you have any thoughts or any anything you want to add?
Yeah, I'll go first. Thank you for that lovely, lovely presentation. I don't think I've ever seen a presentation of breakdown of reading CT scans with, you know, aortas and endografts and leaks as well as you put it tonight. And so I want to thank you for that. And I appreciate you all inviting me to be on this panel. But what I'd like to add is that you made reference to the old tube grafts from the late 90s, which were very, very common to have type 1 and type 2 because of, by virtue of how they were made. And, you know, I don't really recall a lot of type 1A and type 1B endo leaks is what I meant to say. But what I wanted to add is that for a lot of these procedures, and my colleague and partner in crime is on, she can chime in too if she can, Liza Garza Singh is on, is that you will see a type 2 endo leak very commonly after these procedures, right? And up to about 25 to 30% of patients will have a type 2 endo leak post-operatively that you'll find either immediate post-op or up to a month later. Sometimes they're self-limiting and may seal off on their own. Who knows? It also just depends on if the patient is having pain, or as I mentioned before, we went live tonight. We had a patient who came in with abdominal pain and testicular pain. But, you know, I think that a lot of them are self-limiting. Sometimes we don't fix them right away. And when they come back for surveillance, sometimes they may be gone. Or if the sac isn't increasing, we'll just leave it alone. What is your opinion of that, Heather?
You're muted.
I haven't had as much experience with those types of grafts at our facility, so I wouldn't be able to speak to that. But you guys are definitely the experts. The presentation was excellent, Sarah. The only thing that I thought about two things. I love that you talked about how to speak to the patients and helping. I took some notes down because I love the way you said certain things, but because I think that's the hardest part. In my clinical setting is an outpatient. And so we had a patient just the other week that called and had read his CT scan online, and was driving to the emergency room because he thought something was wrong because it had said type 2 endo leak. And I had to talk the guy over to the office and like, no, don't go to the emergency room. Like, let's talk about this. So those words can be really scary. So any way that we can explain it would be great. The other thing that I had thought of was you talked about when the aneurysm is thrombosing. Again, from the outpatient standpoint, some of those symptoms that patients get, like the fever, leukocytosis, and you'll have people calling like, I'm sweating in the bed all night. Like, what is wrong? So those types of things is it. But excellent, excellent presentation.
I'm so glad you brought up those post-op symptoms because I think we don't prepare patients for it, right? And most patients and even, you know, our non-aortic expert teams, we have, you know, at my facility, we have sort of standard post-discharge nurses who call our patients to check on them. And all of the symptoms of a thrombosing sac can mimic symptoms of infection. And so, you know, obviously we don't want to sit on people who have infections, and we're happy to communicate with them, but usually over a quick telemedicine phone call or video, I can, you know, ascertain, particularly if it's a percutaneous access, that this is not an infection, and this is in fact, you know, a benign post-graft, post-stent graft fever.
Post-implant syndrome, very
Yep.
common. We see it all the time. And I'm so glad you brought that up because oftentimes nurses will call and say, oh, he's got a fever. Well, in the absence of leukocytosis, right? Or it's something that we see very, very commonly, the post-implant syndrome. I'm so glad you brought that. Did you hear that?
I didn't hear anything.
Okay, good.
Just you.
So I'm so glad you brought that up. Another thing that I was glad to hear you discuss was how some of the outside places that transfer into our stellar aortic centers will take these measurements in, you know, the sagittal view or not the axial view, and they measure it, you know, the lengthwise, and oh, we've got to get you to a place, it's 11 centimeters, and they're probably going to do surgery on you right away. And oftentimes, you know, we'll care flight the patient in, and we don't ever trust the outside images. A lot of times they're done without contrast or with and without contrast, and we end up, you know, hydrating the patient and then rescanning them. And really, you know, it may just be 5 centimeters or 4.5. And the patients are upset because they were told that, well, I was going to go to surgery right away for this aneurysm. What's going on? They said that they didn't let me eat for 2 days because they didn't know when they'd care flight me in. So I think it's very important to take those measurements in the appropriate view, as you mentioned, and also having a center that is used to measuring and in the proper view. Fortunately for us, our vascular surgeons work very closely with our radiologists, and so they know exactly what we're looking for.
Great.
And even still, our surgeons don't trust the radiologist. It depends on who's reading, right?
That's like rule one for the surgeons at our practice. Get your own images. Yeah.
They've never had their hands inside of a body. They don't know.
Well, and I think it's really important that we look at our own images, right? And that was really why I got really interested. Now, please do not ask me to identify cholecystitis or diverticulosis versus diverticulitis. I mean, all of those general surgery things in the abdomen, you know, unless it's like a roaring something huge that is hard to miss, I'm going to miss
Yeah.
it if I'm really looking at the blood vessels. But as far as if I'm making decisions or I'm part of a team that's making decisions about that blood vessel, I don't want to have to, you know, rely on somebody else's view. I want to look at it myself.
Mhm.
That's good.
Yeah,
Definitely look
agreed.
at your own images.
Yeah.
And it's a hard habit when you're busy and like doing things and moving from one patient to another. And but definitely just pulling up the images and looking at it yourself is most
Mhm.
important. And that's
I'm
how
not
you get
always
better
the
at
best either. I'm not always the best. I have a couple of my colleagues on tonight, Terry Wahardo, Rebecca Granfield, and Liza Singh. And Liza looks at, she's my vascular partner in crime. And, you know, some things, I'm good at the endo leaks. For some reason, I can pick up on those pretty readily. But when you have patients who have had, you know, a type A dissection repair with reimplantation of the coronary buttons and valves carrying, and then they extend their dissection, you know, into the abdominal portion of, you know, their aneurysmal disease. It's pretty difficult for me. So, you know, this is a lesson for me as well. And
Yeah,
I
and
really
dissection, I
appreciate it.
think, is a whole nother beast that we could, you know, think about doing a roundtable on a different day, because what we're looking for is going to be a little bit different there. I thought about adding some dissection stuff in here, but this content was already long enough. And
Yeah.
I think, you know, differentiating between aneurysm and dissection is an important
that would be
part of the
great.
process.
Mhm.
Yeah,
Yeah.
I have something to add. Can you hear me?
Yep.
Yeah.
One of the things that I love about the graphs in general is that they last for a long time. But I really liked your point about, you know, looking at the spine, and as we age, we become kyphotic, right? And so during that time, as our aortas really reshape, that kyphosis will cause these type 1 aneurysms or type 1 leaks. And even they'll, you know, the importance of surveillance to watch for that degeneration of the thoracic portion, so they get the, you know, prior to getting their type 1s. If you follow them long enough, and I'm not talking with CAT scans, even just aortic duplex, like you can, these patients are living long enough now that you can see this happen. And, you know, they'll have these graphs for 20 plus years, and all of a sudden, you know, nature takes over and they'll represent with type 1s. So
Yeah.
great point.
Yeah, and Kristen, I think you make a really good point, which again was beyond what we were going to cover tonight, which is
Yeah.
aortic duplex is a huge game changer. And, you know, we know how important surveillance is, but it's not benign with CAT scan. You know, there's radiation, there's contrast dosing. Radiation is a cumulative effect. Any radiation you get in your body, you carry with you for the rest of your life. And so particularly when we have younger patients, I think this in my practice affects dissection patients more because they present younger, but olds or 60-year-olds who are getting endovascular repair, if they're going to get annual surveillance, I'm glad that we are getting where we need to be with the availability and the accuracy of duplex imaging, because, you know, let's hope that the 60-year-old lives to be 80, but that's 20 surveillance CAT scans we would have done on that patient before we had aortic duplex. So, you know, that could be a topic for another day. We could talk about what we're looking on at duplex. And I think now duplex has really become standard in most practices for surveillance, with occasional CT scans if you don't like what you see on the duplex or it's been 5 years. But yeah, I think that's a really important point, that this is not the only surveillance tool in our arsenal.
Absolutely. The only thing with arterial duplex ultrasounds is that they take so long, right?
And they're so operator dependent.
It is very operator dependent. And, you know, I can speak to this, that Liza and I have had patients transferred in because an incidental abdominal aortic aneurysm was found on some type of, you know, abdominal ultrasound, and then they send us in right away. They don't have the capability of doing the CT scan because either the scanner is down or the patient has CKD 3 or 4. And then when we get the images, we pull it up, put the CD in, and it's like, was this done with a OB-GYN probe. Just done with the type of probe that you would do on a pregnant woman. This is not accurate. It's not accurate, right?
Yes.
And I think that is a big caveat too, is those scans take so long, right?
Yeah. And then if you have the old men with the visceral fat, like,
Yeah.
and
That's
they're so constipated and gassy, like, good luck.
Yeah.
welcome to the South. Yeah. Hmm.
I think I've walked in on our ultrasonographer, basically turning the patient on their flank, trying to look at those posterior endoleaks, just
And
trying to
yet
get
when
any
they get
picture.
good pictures, I'm amazed. I am so amazed at what they're able to get when they're able to get it.
Definitely.
Yeah, that phenomenon you talked about measuring on the oval is called a parallax. That's one of my
Parallax,
favorite
okay.
vascular terms that
I'll
when you
add that
get
to my-
misrepresentation of the AP diameter. So parallax is the thing. You can sound very smart when you say
Yeah,
that.
I will take that.
And I just want to echo excellent presentation. There's a lot of us on here that read CAT scans every day. We can always be better at it. I know one of our PAs is on tonight, Rachel McPherson, and she's much better at reading some of the CTs than, some of our radiologists. So shout out to her and all the work she does. Just it takes constant, repetitive, looking and constant teaching. If you have mentors, if you have people that are good, just keep looking at it with it. It's just over and over and over. It takes a lot of time just to recognize aortic pathologies, but then when you zoom out to that 30,000 foot view, you're like, oh, there's a renal cyst. Oh my God, their liver, they're bleeding.
Right?
It does take some time to
Yeah.
get there, but I really appreciated your presentation tonight.
Thank you so much. You can put it out to the chat. Does anybody have any other questions or any comments? Alyssa said, amen on the operator dependent. Not all sonographers are created equal. Thank you, Liza.
I'd like to thank my Baylor Scott and White colleagues for showing up. Kelly Dorsey, Claudette Solis, Nanette Thomas, and of course, everyone.
Yeah, thanks for having me on the panel, and thanks for a great presentation. And I see Mel. She's one of our nurse practitioners here that attended, so thank you.
Yeah, and I've got new NPs and PAs on, so this is really informative for them too.
Adrian and Alyssa. She's like, ma'am, I'm here.
And I want to
Sorry,
thank,
Adrian.
and I want to thank my University of Maryland colleagues. We've got Barbosa and Bing from our vascular floor, and my partners, Mary and Natalie, and one of our nurse educators, Rachel. So this is really awesome. It's really great to collaborate. Welcome, Anthony, to the vascular world. We're so happy to have you in SVN. Thank you, Rebecca. NPs do not get enough education about imaging. I totally agree. We had 1 2-hour class about reading a chest x-ray.
Yeah.
No, we
Yeah.
didn't get any education on it. It's been just strictly on the job training.
Yeah.
Wow. And I have to say, this is a goal for the Society for Vascular Nursing for educational content that's not just being delivered in a conference fashion. I really appreciate the board members that are on tonight, Heather and Gabrielle, for joining in with their expertise, and Sarah has been an amazing point person for our education committee. And if anybody, and I know Ann Luciano from University of Michigan is on tonight too. She's also part of our education committee. If you or any of your friends would like to get involved and help us, just let us know, send us a chat, send us an email, whatever it is. We'd be glad to have you on any of our committees, just pushing forward better educational offerings and, any content we can put on the website that further, helps with patient or the new to vascular provider or nurse or whoever. So yeah, feel free to join us. It's fun. The water, jump in the water. So with that, I think we'll call it a wrap, and everyone have a good evening. Thanks.
Great. Thank you.